Great. Hello, good morning, good afternoon, everyone. Good morning to those on the West Coast. I see people are still coming into the room. I want to welcome you to this webinar on peer support services, peer support roles within crisis services. This is a topic of growing interest, and we're excited to be rolling out both this webinar and a future learning community on the topic. I want to invite everybody to introduce themselves in the chat box. Let us know who you are, where you're from. I love to see where people are coming from. You can also ask any questions you like in the chat box, questions, comments. You might see a familiar name attending, and you can go ahead and send a personal message, a personal greeting to a friend. That's okay. You're not going to bother anyone here doing that. It's one of the bennies of virtual trainings. If you should run into trouble with your audio, there is a phone number that you can call in. So you can change your audio source or troubleshoot by just clicking this arrow. As you can see, the red box with the red arrow pointing down, and select a different source for your speaker or microphone. The call-in number is in the invitation, so you shouldn't have trouble finding that. Again, any questions or comments, you will be on mute the whole time, but we really try to get people involved through the chat box. Share your personal opinions, your resources, questions, comments, complaints even. We like to hear about it, so go ahead. If you want to change your view, I think I'm the only speaker who will be showing. You can close me out by pushing on the top, the bar on top of my face, then that will work okay. Or you can change your view right there. Maybe not relevant for this training. So again, today, a little more information how this works. This event will be recorded, is being recorded, and will be available for viewing on C4's YouTube channel. So if you have friends or colleagues you think who would enjoy this, this is a great place to send them. On our YouTube channel, we have many wonderful presentations. And at any point, in the future, if you want training or technical assistance from C4, you can go ahead and just email us, and we are happy to respond. So welcome, everyone. My name is Cheryl Gagne. I am a senior associate here at C4 Innovations. That SCD, all that means is that I have a doctor in science in psychiatric rehabilitation. So that has been my background for many decades. I am a person in recovery from both mental illness and substance use disorders. And I have to say, from personal experience, have been coerced into crisis services in my adulthood. My early adulthood. It's been a couple of decades, but I do still have this very powerful memory of engaging in kind of crisis-oriented services. So we're going to talk about that today, and we're going to do that by kind of just looking really quickly at the current situation. We could talk for days about the problems with the current situation, but we're not going to do that. We're just going to touch on some points. I'm going to present to you a new model of kind of understanding crisis systems, so-called crisis now model. Many regions and mental health organizations have really embraced this model, so we'll take a look at that today. Then we're going to launch into sort of the variety of peer roles within these crisis services, within the whole array of crisis service. I will go ahead and talk about those different roles. We'll talk about challenges for crisis workers, the peer workforce within crisis services. talk about some moving forward, some next steps, and then we'll go ahead and have some discussion. But first, I'd like to know, who are you? Who are you? And so we have just a couple of poll questions that'll help us get a better sense of, who's attending this. And we have some categories that best describe your work role and best describes your place of employment. So it says here, hosts and panelists cannot vote. So I'm inviting all of you to please go ahead and vote. You should be seeing a poll question right in the middle of your screen right now. Do you see it? If you do, go right ahead and respond. Just check where you best fit. Okay. Is everyone voting? It says that everyone can see this. We'll give it another minute. Okay, we can add other to question two. And Ruth, a couple of people who none of the above or other, go ahead and just type it in the chat. I think that's fine. Where you're coming from, we'll get a better sense of that. People have multiple roles, absolutely. Okay, so go ahead and put it, if you have other for question two, go ahead and type it in. All right. Public Defender's Office, wonderful. So happy to hear that. Defense lawyers. Beautiful. Okay, why don't we look at the results? Couldn't answer the poll. I'm sorry about that. State government, great. Community health worker, super glad to have you in the house. All right, you want to go ahead and just show us the results of that poll, please? All right. So as I would have predicted, a large percentage of you are peer support workers, recovery coaches, a few direct service members, even fewer social workers, a couple therapists, counselors. A great number of you identify as other, which has been filled in some ways. Other roles are crisis response program manager, residential counselor, working for state government, administrative support. So all over the spectrum. All right. And then in terms of place of employment, what about that? Did I just close could you put that back up, please? The survey results. Maybe I just needed to scroll. Okay, what best describes a lot of peer-run organizations, recovered community-run organizations, a majority working in behavioral health clinics, very few in primary care, not surprising, community-based service providers. And I think of those as kind of non-medical, non-treatment, more kind of recovery support services, employment, housing, benefits, community membership. Only 1% is currently working in a crisis stabilization unit, and just a few in ERs and inpatient units. One person mentioned an Indigenous recovery center, wonderful, many, many more. So we're glad to have you with us. This variety of participants is really wonderful. And as we move through the topics, I anticipate that people will have very different perspectives and experiences with both the current crisis care system, and I'm using kind of air quotes, and the house recovery now. So a behavioral health crisis, just to get a couple of definitions out there, refers to an event or a situation associated with real or just potential disruption of stability and safety as a result of a behavioral health condition. So typical ones, that are frequently alert crisis response may be, somebody who's experiencing intense mania, or someone whose psychosis has caused concern from other people, somebody who is feeling very suicidal, maybe a person in very chaotic drug use. Certainly an overdose is frequently a cause of crisis. And a crisis system, behavioral health crisis system, should involve an array or a continuum of components, processes, services that are all linked together and managed cooperatively, right? That they're coordinated services, not this fragmented, siloed system, quote, of services that are currently available in some communities, and in other communities, it's not even that it's fragmented, it just does not exist. And some of the fallout of that, one model I want you to look at is that when we think about a behavioral health crisis, it's certainly more than the situation and the event. And this is a kind of a social ecological model for, I think they focus primarily on suicide or violent behavior, but looking at the kind of in a much more holistic way, and understanding that there are individual risks and protective factors. There are relationship risks and protective factors, right? There are community risks and protective factors, as well as societal level risks and protective factors. And those risks and protective factors are all things that can be addressed as well in a lot of crisis prevention, suicide prevention, good high quality, addiction treatment or mental health treatment, could be construed as crisis prevention service and could fit in a much more ecological model. Often in crisis services, we're really just intervening with the individual, right? So the actual, once a crisis happens, it all comes down to the individual. And tend not to address some of the relationship, community, or certainly societal issues that really kind of fueled the crisis, right? So I'm not going to go into a lot of that, but I brought it up because I want people to see crisis as more than just that single, event or situation that brings the individual to the attention of authorities or mental health authorities, but seeing it in the context of a whole ecological system, not just a system of care, but beyond that. And again, that would be a great training in looking at that, but that's not what we're here for today. So if we look at just kind of what are the current system of crisis care, what are the issues with it, what are people talking about, what's in the literature as potential problems in our newspapers, and these kind of summarize it. Certainly an over-reliance on law enforcement. Law enforcement isn't any happier with that situation than people who are experiencing a crisis, who have not broken the law, who encounter law enforcement, right? That whole over-involvement of law or over-reliance on law enforcement for many, many, many communities, that is their mobile crisis response, law enforcement. Some communities have really trained law enforcement in CTI, crisis intervention training, which may be necessary, but it's not really sufficient to bring dramatic changes to our crisis care system, right? If the value, even with training, unless police officers are getting lots more support for their crisis intervention work, then it's not likely to bring about dramatic behavior changes for law enforcement. And we've all read, articles in the past several years of people who've called for help or family members who've called for help who have actually encountered law enforcement and been shot by law enforcement. certainly an over-reliance on emergency departments, hospital emergency departments, which, were never designed to address behavioral health crisis. And though lately, people have been talking about, up to 20% of the people who visit hospital emergency rooms are people with a behavioral health issue, either a recent overdose or a psychiatric crisis. The phenomenon of psychiatric boarding in emergency rooms, emergency departments, has been very much in the news. People spending days, days strapped to a gurney without any treatment, without any attendance. Emergency rooms as they stand, were again not well suited for people who are experiencing behavioral health crises. So this is potentially traumatizing for all people involved. So, law enforcement doesn't feel competent with this. Some emergency rooms, nurses, physicians, workers don't feel confident or competent in dealing with this. There aren't enough services. It's potentially traumatizing. And, for family members and certainly for people who are experiencing a severe crisis. It does increase the level of violence. And so that is important to know. Certainly, anytime someone's freedom is taken away, it is much more likely to elicit violence. Human beings respond to restriction with more aggression. It's just, it just happens. If you've ever been in a crowded airport, you've seen that, right? People feel trapped and you see a lot more aggression. It's just human nature. And so anytime, crisis response is, very coercive with law enforcement, where a person has no voice, choice, or, and may be restrained, they're much more prone to violence than if another way has been offered. Certainly, we've seen that there's a lack of effective responses to crisis, both in the emergency rooms and in kind of non-existent service programs. So this next one, the lack of availability of needed services and supports, which has really led to psychiatric boarding. There are probably services and supports that are needed that don't even exist now, for people who are experiencing what is called a behavioral health crisis. The other thing, sorry about this, I've got to move some things around on my screen. So psychiatric boarding is often the result of this, just there's no place to send this person. There are no, respite places for someone who needs short term. There may be no inpatient beds if that's what's needed. So again, the current crisis system is rife with problems. There aren't too many people saying, oh, we're doing a really good job with this crisis response for people with, behavioral health conditions. The Crisis Now framework has come out in the last several years. This is a response mostly developed by two men, David Covington, who's from Recovery Innovations International, and Mike Hogan, who's been a mental health commissioner in states and it's been around forever, who runs Hogan's and Associates. And they've really thought through like what needs to happen. So in a most general high level way, they're saying a crisis framework really needs to, have someone to talk to, someone to respond, and a place to go. Now, for some people, someone to talk to is enough. So we talk about crisis hotlines and warm lines, making those available 24/7 for people who may be in crisis and would benefit from just talking with people about what's happening in their lives. Mobile crisis support, a little bit higher level of intervention. The team goes out and sees what's happening in this home, in this family. Mobile crisis supports are used often in bigger cities. So I know here in Boston, we have the BEST, which is the Boston Emergency Mobile Team, and they come and, you know, assist people who are experiencing crisis. So that's, you know, and sometimes crises are resolved right at home or right on the street. Issues are addressed, plans are made, the team can, you know, do assessments, triage, help people make some decisions, maybe even connect them to services immediately. A next level of care is what's known as this 23-hour kind of triage and assessment. No more psychiatric boarding in an emergency room, but rather the, you know, it goes into a more comfortable place. The lounge chair logo is not mistaken, because a lot of these crisis and a stabilization short term, you know, do have like lazy boy loungers in them. And, you know, so much more comfortable than sitting in a, you know, a hospital emergency room, waiting room, and, you know, people can attend to a person's physical needs and again, make plans. And then short-term stabilization. Some people may need more than, you know, several hours, may need several days to kind of get back on their feet again, feeling better, feeling well enough to go home and attend to, you know, all the stuff that's waiting there for them. But the goal being that there will be lots of services available. One of the big things Crisis Now focuses on is this kind of real-time information. If anyone's ever worked the phones or in an ER, you know it's really hard to know where are their beds, you know. And I can tell a personal story trying to get my sister a bed. You know, it was 2 full days of phone calling, and I work in the system. Like I work in the system, and there was nothing, you know, that took her insurance or that was available, or that there was nothing available. So having real-time information about what is available right now, you know, particularly helpful if somebody needs a detox, or if somebody is really struggling with, you know, such intense, you know, psychiatric symptoms that they need help immediately. Direct connections with real-time scheduling, so that, you know, again, people don't walk away without any warm handoff. The idea being that there is a, a warm handoff, a link, not a card to say, you know, go to the community mental health system on Tuesday, or call here for an appointment. You know, that's often too many steps for somebody who is distressed. Mobile crisis services responses that can avoid emergency departments and avoid jails, because one of the other bad outcomes of the current system is that, you know, mental illness and addiction have really been criminalized. So if a police officer goes and the person is, you know, at all assaultive, you know, they may be brought to jail, where they won't get psychiatric treatment, which would be even, you know, more traumatizing. That urgent care settings are warm and welcoming, you know, soft lights, more comfortable, you know, chairs, etc. You know, a lot of hospitality skills, you know, very unlike an experience in the emergency room. So that's important to keep in mind, that it isn't just about doing things in different places, but rather doing things in a different way. And there have been a lot of comments about more training needing for law enforcement and first responders to de-escalate. Yep, mobile crisis team, help those residents who call 911. Extra support will reduce those potentially deadly interactions. And I've seen this work. I have seen some amazing, you know, police officers who have gone in and de-escalated situations beautifully. we had a neighbor across the street for many years who, I mean, he was very well known to the small town police, but had some very serious, scary behaviors sometimes when he used alcohol, and sort of combined with some, probably a bipolar diagnosis. And neighbors would complain, police would come, and they actually did a really good job, and get it, but they knew him, and they knew his family. They weren't going to shoot him, because they knew the whole family. And even once, he had a knife, but they were very careful, and did have to use physical restraints, but it didn't escalate beyond that. And most of the time, I mean, witnessed it several times. Most of the time, they were really able to talk him down, encourage him to come with them. So it's so some people, yes, CIT back home, that's gotten a lot of great press. Okay. CIT. So crisis care with support and trust, with more partnerships with the person experiencing crisis, like really attempting to engage the person into understanding what's happening for you. What is it that you need? Rather than, which often happens in emergency rooms, person may be restrained to a bed, given medication, but there's no real conversation about, so tell me what happened, how did this happen, what do you think will help? So from right at the beginning, helping to engage people to have more of a voice, more choices in their own care. Some of the components that Crisis Now has proposed, and these have been, SAMHSA endorses those, NASHBID is endorsing them, other organizations, again, nationally level provider organizations are really thinking this is a good way to look at crises these days. That there is a crisis hub, sort of a regional central hub, 24/7 information up to date about where are the resources, what can we offer. So this informational hub. They also talk about something they call, which I don't really like, is kind of air traffic control, and sort of the call comes in and I don't disengage until, the other air traffic controller kind of takes over. So a very warm handoff, whether it's telephonic or personal, but that there's this idea of, now I'm kind of guiding this person, and I'm not going to stop until somebody else has kind of stepped up and taken that. The crisis call lines of using, both peer-run warm lines. There are a lot of warm-like issues that get people into psychiatric crisis, just that can be talked through with a peer. One great example of this is the Rocky Mountain Crisis Partners, who operate their suicide prevention hotline for the whole state of Colorado. They, when people come in, they have a choice. Would you like to speak with a peer support specialist or some clinical assistance right now? And people make that choice right from the jump. And there's deep communication and coordination between the hot and warm kind of response, because sometimes it may feel really hot at the beginning and clinical and talking, and they discover, there are kind of warmer issues that are, that peer support would be able to address. Certainly crisis trained peer supporters, a number of people have talked about that. Medical triage and screening. I mean, that's always been the reason why people have been brought to the emergency room, even if there is, say, a detox bed open. We're trying to eliminate that this approach tries to eliminate that, to allow the crisis triage, the medical triage rather, and screening to be able to be done in a crisis stabilization unit, not in hospital emergency room. Certainly, if something were discovered in that triage unit that required much more intensive medical treatment, the person could be transported to but it didn't make sense for everybody to start ER, because again, that's what backs up the system. Mobile crisis teams, there's some very skilled people who are very, skilled and comfortable, competent at de-escalating even situations that seem quite frightening to most of us. Behavioral health urgent care, and these have been, I'll give you some examples, but they're really kind of been imagined and have been implemented as kind of a cozier crisis stabilization unit. Sometimes behavioral urgent care just could be, behavioral care clinic that has evening and night hours, where people can go in for urgent assistance. Intensive ongoing support. This is often a piece that is not part of a lot of systems. People are not kind of picking up or getting handoff or linked to organizations that can provide ongoing intensive support. Again, one of the benefits of a warm line connected with a hotline is that the peer support providers are often able to provide this ongoing intensive support around practical matters of living. 24-hour evaluation and support, residential crisis support. Certainly, they'll probably always need, need for hospitals, and then transportation. That's also whether that is a, crisis team or a, even an Uber to go pick up somebody who needs some support, some assistance. So that's the continuum. We know that the principles that they've articulated are pretty clear. They want them to be recovery oriented. And by that, it's really, being hopeful for people, recognizing that a person in crisis today could be doing well, a year from now, and giving back to the community and, leading a life of purpose and meaning. Sometimes, in particular, working in crisis environments, when you see people frequently, it's hard to have a recovery orientation. And some of the attitudes that come out of that are, conversations about, I'll only rescue somebody with an opioid overdose twice, 3 times they're out, I'm not Narcanning them again. And we've heard people promote policies like this, right? I did work with a man who was the highest user of emergency services in the whole Metro Boston area. A Hughes, they called him, high user of emergency services. And because they were doing research, Medicaid was doing research, we were able to count, he had 217 admissions to the ER in 18 months. Now, some of those people working with him may have been like, what are we doing? This guy, if they don't embrace recovery, it's easy to feel really hopeless. And I can say this man is, been in recovery, doing very well for 11 years. He's gives a lot back to his community. He's just a generous, loving, very giving person. And the world would be a much worse place without him. And so recognizing the importance of each person's life here on earth, that's what recovery is about. It's not about abstinence necessarily. It's not about never having symptoms. It's really about faith in the growth potential of each and every person, that each person has can contribute. So I'm going to go through these quickly, but we're familiar with trauma-informed care, safer suicide care, valuing security and safety for both staff and people using services, and then more partnership with law enforcement, of really bringing them in as partners. And that's been done in a very big way with the opioid overdose crisis. So a living room is an example. I know Recovery Innovations runs several of these around the world. They have one in New Zealand and they're a bunch in the United States, but it is a safe place to rest, relax, get some support. They don't use seclusion and restraints. It looks like home, it feels like home. Um, Linkages to emergency housing. A lot of times people are in crisis because of very practical things. I'm out of money, too much month at the end of the money. I'm feeling despair, suicidal because I'm poor, and having kind of emergency referrals to resources that people desperately need is helpful. And generally, no law enforcement. People do not come in shackles to these places. And some images, just to give you, it's not homey really, but it's not a psychiatric waiting room, as you can see. I like the snacks, and we all know from working with people, offering a snack. Offering a snack can go a long way. Making someone a cup of tea can be a very powerful form of connecting. So these are a couple of the environments. Another model, kind of very different, but for some people preferred models, is the peer respite. And there are peer respite houses all over the US. Not enough, but but they're voluntary. That's an important thing. So peer respite rarely, very, 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 very rarely encounter aggression and violence. And part of this all of this has to do with the fact that it is totally voluntary. If you don't like it, you can leave, So operates 24 hours a day, very home-like. They're operated by people who have either mental health diagnoses or who have experienced trauma, extreme stress. Somebody who in the comment box working at the living room, people feel welcome, safe, not judged, accepted. They trust the recovery support specialist. So that's huge. It's so much different from having a security guard standing out your door, having a nurse who's way too busy to even begin to attend to anything you need, even if it's a blanket or a drink of water. To have people who value hospitality and non-judgmental acceptance. We do know currently peer support specialists, recovery coaches are working in a variety of crisis services already. And some fit very well and are super satisfied with their jobs. And some people are having a really hard time with sort of resonating with their code of ethics and what is being done in their program. Yeah. So there's a question about, am I a proponent of law enforcement as crisis responders, transporting people in cars instead of vans or ambulances? Absolutely not. It is ideal if law enforcement are not involved. But if they are, because of, this person is not known to us, there's rumor of them having a knife, there are fears, we just don't know this person. If law enforcement are part of the mental health crisis response team, that they have their role, but so do the mental health or peer specialists who really have the skills of de-escalating and establishing kind of a next few steps. Always better to be transported in, a car or a van. Ambulance is a little intense, but that sometimes happens too. So we see peer support specialists, recovery coaches in emergency departments, working on inpatient units, both again for addiction treatment and mental health. Staff in peer-run residentials or staff in more of crisis stabilization units. There are peer support workers on mobile crisis teams. Fewer than in some other environments. It's a tough environment for a peer to be able to stay true to their code of ethics. There could be peer support in a crisis care center, like those stabilization units. Harm reductionists, I think of as, crisis prevention people, or they respond a lot to crisis in terms of overdose and wound care and attending to people who are at high risk for death. Outreach team members are absolutely part of that, and certainly staff in peer-run drop-in centers or staff in recovery community organizations. And why like peer support? So why should we even have peer support? While peers say it's really hard to work in these environments, it's really challenging. It often, I rub up against my code of ethics. It's, I feel upset many times. There's also a very strong feeling that peers need to be in this work environment, that peer support needs to be part of the offering there. People need an opportunity to meet people who are willing to offer a sense of connection and belonging. This is us. Whereas often in a hospital, you very much feel othered, you're the patient. And so we have a powerful need for connection and belonging. And for many people in crisis, that sense of belonging has been thwarted by, who anything could get in the way, but people are feeling very hopeless and isolated. And peer support is the one intervention that really addresses that. Yes, medication may be helpful, but a sense of belonging and purpose is also key, very important. So also a shared sense of hope and freedom. Peer support really tries to speak to the individual's own sense of agency and autonomy, and what is it that you want, help them exercise their voice, and through this, can strengthen their sense of hope. And then, peers are just really good. Peer support workers and peer recovery coaches are very, very good at offering just really practical supports and strategies for what to do next. We know these are the principles of peer support, and they've been woven into a lot of behavioral health services, but less so in crisis care. So that's voluntary. Often crisis care is not voluntary, non-judgmental, non-clinical, empathetic, respectful, etc. So we focus on peer supports in part because they do fill a relatively new and unique role in behavioral health care systems, right? Historically, there was not a big role for peer workers. A supervisor's colleague may not understand what peer support services are, what it is. They might not understand it well enough. The organization may not be aligned with the same values as peer workers, right? They might have totally different values that are sometimes in conflict. I might value, well, we all value safety. Some may value safety over any other zero risk kind of safety over any kind of person engagement. Providing organizational support and high quality supervision. Again, with lack of seasoned peer workforce, there may not be enough to provide that supervision. And supervision is so key for worker satisfaction and good ethical practice. So, and then we see that, peer support is essential in these environments. That might be the one voice or person who truly makes an alliance and, invites a person into relationship. We know that peers are unique in some ways in that they're, provide non-clinical recovery support. They're not looking at diagnoses, right? They're really looking at much more, what are the disadvantages or problems this person is contending with? What are their strengths? How can we help them get the resources, supports that they need? Peer workers do follow a professional code of ethics on their own. They have specific competencies related to peer practice. They do share their lived experiences, their personal experiences. That's unlike most other professions. And they frankly, they may not be the only ones, but they do contend with a lot of prejudice, discrimination, stigma in the workplace. So there's always a level of distrust kind of when a new profession comes into an organization. But this has been, I think, more tainted by stigma than most. Code of ethics, while there isn't sort of a national code of ethics for peer workers, they all have a lot in common. And so recruiting for crisis services, the need for very detailed job descriptions, positions need to be explicit about these requirements. It's also sensible to articulate the values of your program so people can make a good decision about, is this a good match for me? It will also help you attract some of the right candidates. Some of the, when we think about retention of peer workers, and actually this goes for not just peer workers. I just worked with a hospital last week whose average length of stay from, recovery specialists, mental health specialists was under a year. So it's not just peer roles where people are having trouble retaining. With restaurants paying $20 an hour, who's going to work hard like that for that little money? So good pay and benefits, flexible work hours, great supervision, an organization that is really trying to become much more recovery oriented, person centered. Values will be in more alignment, and also having kind of meaningful interactions with their colleagues, like feeling part of a team. We do different things, but we all want the same thing for the person. And we all value what each other brings to the table. Yes. So comments on money. Okay, good. So I'm going to skip over that. I'm going to talk about what other things that peers do very much in the system is crisis prevention. And we really need to look much more intensely at prevention. The Crisis Now system is great to propose. If the whole country moves there, people are going to be better off. But without, good crisis prevention services, then it's going to continue to be problematic. And so I just included, these are like just some primary preventions. They have nothing to do with mental health really, but primary preventions, preventing crisis, preventing suicidality, preventing hard times for special populations, so we know for the elderly, I'm approaching the elderly. I had a meeting with Native groups and they let me know I was an elder. So that was, which has status. So that felt good. Friendly neighbors, telephone outreach, help alerts, the med alert stuff, elder services, assisted living, helping people stay in their homes, for adolescents, parental support, nothing like it, training parents to be much more supportive of their adolescent. School support, again, having less punitive, more trauma-informed schools, anti-bullying programs. You could say, a lot of the sports groups and teen groups are all kind of, let's prevent crisis around adolescence, where the risks are pretty high. With veterans, there's a lot, suicide prevention education, mental health education, more reentry support for people who've been deployed and coming back. For gun owners, there's even primary prevention, given the large number of suicides for gun owners. Firearm instructor education, which addresses suicide and gun safety. There's a gun shop project running in several parts of the country. I don't think it's across the whole country, but that is, also, again, teaches people about gun safety and suicide risk. And then there are gun owner coalitions who have really, they're not all about, Second Amendment rights, but rather safety. How can we keep, our guns safe from our children or from our elders or from our neighbor who may be, feeling suicidal. So we think about crisis prevention services, those that are more maybe tertiary prevention directly for people who may have had some mental health or substance use issues, and kind of identified as potentially having some challenges. We know that transition programs to help people leaving hospitals and prisons are very important. The data that came out that people leaving hospital are at a higher risk of suicide than people who never go into hospital. That period of time shortly after leaving hospital, people are at much higher risk of suicide. People leaving prison are at much higher risk of drug overdoses than the average person. So transition programs that really help people with kind of the practical strategies of getting back to life. Crisis prevention plans, a lot of peer organizations will help, peer support. A group called Alternatives to Suicide. I hope you look it up because we don't have time to talk about it today, but it's a fabulous, peer-run intervention, non-clinical, just kind of the same line of hearing voices, for people who hear voices, to really just kind of talk about suicidality, talk about suicide ideation, normalize it, helping people again find purpose and meaning. The RAP plan, which is the Wellness Recovery Action Plan, or a toolbox for tough times, enhanced support, harm reduction, warm lines, this never use alone. I don't know if you guys are, I should have put the number in here, an 800 number. So if somebody has an opioid use disorder, is using, doesn't have someone they can call someone who will stay with them and make sure they're all right. And there was just a big article in our local paper about a person who was rescued due to never use alone. So those are just examples of crisis prevention. We know that communities are investing to build an improved crisis care system. This kind of goes along with the 988 rollout. And if you don't know about that, please look it up. The suicide hotline, the National Suicide Hotline is hoping to go to a 3-digit 988 number, similar to 999. That would be, deploy services and supports. But a lot of systems are getting involved, and it might be an opportunity for you to have a voice and a choice. Thank you for that, Yaren. Peer support workers do fill a very important role in the provision of crisis support in a wide range of environments. Sometimes, peers are very good at helping people reframe crises, and look at the opportunities for growth within that crisis, and to connect with others who may be grappling with similar, social, economic issues. And then peer-run programs also offer effective alternatives to emergency department treatment. Just kind of summarize that. This was a very quick addressing the topic, but it was really designed to be a teaser to talk about the learning community that is coming up next month. We start on September 22nd. Learning community is an opportunity for people to come together. This one is 8 weeks. We run it with about a 45-minute lecture each week, presentation, and then immediately a 45-minute small group discussion about how do we take what we just heard and begin to implement it into our own practice, our own programs, our own community. So people who've participated in the past, it's really anyone, people, program directors, administrators, managers, supervisors, peer, recovery coaches, peer specialists, any provider who really wants to know more about it. And we talk about what are the specific competencies that peers need. We understand peer support is peer support is peer support, no matter what environment, but there are additional competencies peers may need in terms of negotiating their role in this service. We want to talk about, how to cultivate strong teams, looking at safety protocols in different environments, understanding the value of peer support, networks of post-crisis for people in need. And we will talk some about supervision and kind of how to improve supervision in crisis services. What are some of the better strategies? Explore strategies for solving some of those system level problems, issues, challenges. The other thing, it's not an explicit learning objective, but it was a beautiful outcome, is that people found real camaraderie, connection that lasted beyond the learning community, so there was a real benefit of people being together for a length of time. And I know that just now the link is in the chat box, but I also have the link here on the slide if you want to. It does have a cost. It is $550 if your program can splurge for that. We do have a limited number of scholarships that we can give, depending on how many people enroll who can pay. We can offer some scholarships, and those are most for people from very grassroots organizations, low budget, lower income kinds of, if you think about it that way. All right, one more slide and then I can do. So we have the learning community starting on September 22nd. You can catch this webinar recording, and again, other webinars coming up or that have already been archived on our YouTube channel, and also staying up to date. You can get on our mailing list about our newsletter and future events. So I thank you all for the comments. So a good question was, there've been a lot of good questions, but how can peers and supervisors stay true to peer principles when working in crisis care environment, especially when some of the crisis is involuntary? Yes, and that's true and creates a values conflicts. And I think being very explicit about where the values conflicts are and very careful about the job description within that. So a peer specialist would never be involved in, performing restraints or coercing someone into signing a voluntary, being coercive. That staying away from coercive activities and really clarifying what it is the peer can do. So in some of the living room models, peers might sit and just keep company with somebody, talk, play cards, drink a soda, talk about kind of what resources are out there after, maybe share a little bit about their own experience in crisis care, inspiring some hope for change. So I do think it is very, it's critical to be really clear about the roles and responsibilities that a peer worker can take within this environment. I did have knew someone who was working as a peer specialist in a forensic setting, and that seems antithetical, and yet this person was really able to do great work with it was mostly men who were in a very restrictive environment, but within that kind of restrictive environment, they were able to help people exercise their will, their agency, to begin to imagine, future environments as well. And so there is that. So I want to leave you with, um, well, first of all, my thanks for coming this afternoon, this morning on the West Coast. My hope that you will think about joining the learning community. If you have other folks you think, oh, they would be great, or if you have a person in, might have some authority who you'd like to have involved, go ahead and send them the link. Um, okay, so thank you so much for your attention and participation. It's really made the hour fly by. So we'll talk again soon. Take good care.